So today, it's I think the fourth session of the certificate course on thyroid and male hypogonadism. I welcome you all on behalf of API and Indian College of Physicians. I congratulate Dr. Alka Deshpande, Dean ICP, to start this very innovative academic event. And I congratulate our course directors, Dr. Minal Mohit and Dr. Dr.S.K.Singh, for putting very hard work and sincere efforts in preparing these very important modules. And I think it's a very great academic activity, which will go a long way in benefiting all PG students and practicing physicians who see a lot of thyroid cases and all the cases that in their practice. I congratulate them. I welcome all the delegates who are attending these important sessions. I hand over to Dr. Dr.S.K.Singh to please go ahead with this today's session of certificate course.
Thank you, sir. Thank you for your kind words. And today again, we will have very long module on the thyroid by Dr. Minal Mohit. As always, we hope it will be very good. And the other speakers for the male hypogonadism will be Dr. S.K.Singh, who is professor and head of the endocrinology, and also director of Institute of Medical Sciences, BHU. And Dr. Sujoy Ghosh, who is also professor of endocrinology of Medical College, Kolkatta. And he is also secretary of the honorary secretary of Endocrine Society of India. And I hope, like previous meetings, this meeting will be also beneficial to all the participants. And without wasting time, I request Dr. Minal Mohit to start the thyroid module, thyroid course lecture. So Dr. Minal, please you start.
Thank you so much, sir, for your kind words. Dr. Alka ma'am will not be joining today, sir.
Is busy, she will not be able to join. And Dr. Grishma, Dr. Parikh sir is in the Siliguri. Dr. Alka madam is also there in the Siliguri.
Okay. So I'll just, with your kind permission, today we have combined two modules, sir. We'll be taking the module 4th and module 5th today. The 4th module is a small module on autoimmune thyroid diseases. So with your kind permission, I will just start sharing my screen. So if it is visible, sir, my slides are visible, sir?
Yes, yes, Dr. Meena.
Right, thank you, ma'am. So very good afternoon, all of you. So this is the 4th module, 4th and the 5th module that we will be taking together, the 4th being a very small one. It's a brief introduction to autoimmune thyroid diseases. As we all understand that most of the thyroid disorders are autoimmune in nature. So what are the different autoantibodies that are actually present? We find the most commonly advised as a lab test is a TPO antibody, that is thyroid peroxidase. Then the second commonly prescribed as a lab test is a thyroglobulin, that is a anti-TG. Like we usually prescribe TPO antibodies and TGA antibodies. The third commonly prescribed and are usually more often used to diagnose the Graves' disease is the TSH receptor antibodies. The TPO and TGA antibodies, they are not directly involved in specific pathology, but they are very frequently present in the common population also. Then the anti-TSH receptor antibodies, which we are commonly prescribing, they are the TSH receptor antibodies, commonly known as either TRAB or TSI. They are the antibodies that are present commonly in the Graves' disease. And the thyroid blocking antibodies are most commonly responsible for Hashimoto's thyroiditis. So this is the autoimmune profile of the thyroid disorders, that the two autoimmune disorders commonly found are Graves' and Hashimoto's thyroiditis. And the antibodies that are commonly used to detect, diagnose, or assess the patients are the TPO, TGA, and the TSH receptor antibodies. They can be, the receptor antibodies can be either stimulating or blocking. So the etiology of autoimmune thyroid disorders is usually multifactorial. There has to be a genetic predisposition. When there is genetic predisposition, what we really mean is that there are specific HLAs or the CTLAs CD4 or CD40 present, thyroglobulin present, the TSH receptor genes present. And in this population who are genetically predisposed, if they get the right environmental exposure in terms of either a deficiency of iodine or overdosing of iodine, selenium, certain drug exposure, certain viral and bacterial infections, stress and environmental pollutions, the environmental hazards, then these patients with certain endogenous factors at the right time, maybe around puberty, maybe around pregnancy, during the periods of stress or rapid growth, around menopause, aging, or during their phases of emotional vulnerability, and specifically the women, the female sex. So these are the common interacting factors that finally lead to the overexpression of the autoantibody or the autoimmune profile that leads to the clinical manifestations of the thyroid disorders. If we look into the prevalence that we studied last time also, women are more highly affected by the autoimmune disorders. So the prevalence of these autoimmune disorders is almost double in women as compared to men. And the prevalence, if you look for our hypo disorders, are more common. Almost 90 to 95% of the cases will be hypo, and we get lesser prevalence, lesser burden of hyper disorders. And even hyper or hypo, irrespective of the function of the thyroid gland, the prevalence is more always in women. In India, if you look at the Indian data, Indian population studies, you will find that the data is almost 20% of the adult population is already positive for either TPO antibodies or TGA antibodies. They all may not be clinically suffering from thyroid disorders. So if you look at the thyroid disorders and the correlation of the antibodies, you will find that there is still another 10% population who is positive for antibodies, but is not clinically affected. So these antibodies do not have a 100% diagnostic role, but they do exist and they do play a role in pathophysiology. So again, in the landmark study where the Hashimoto's data was studied in almost 6,000 population, this was a study on school girls, it was found that the incidence of antibody prevalence is present, and that antibody prevalence again has not a direct correlation with the clinical scenario. So if we look at the thyroiditis status, there are either painful conditions or painless conditions. So the most common painless thyroiditis picture you will find with Hashimoto's. It's an autoimmune, chronic autoimmune condition. It can be hyper or hypo. Then next commonly clinical entity which we come across is the postpartum autoimmune thyroiditis. It's a subacute condition. Again, the women can go through a triple phase of hyper, euthyroid, and a hypothyroid phase. Then we have the subacute lymphocytic thyroiditis. Then the non-autoimmune, it can be a drug-induced thyroiditis. It can be cortisone or amiodarone-induced thyroiditis. Then as we just have gone through the case studies in the pre-test, there can be interleukin-induced thyroiditis. All these can be acute or subacute. The patient clinically can be hyper or hypo. Again, lithium-induced autoimmune thyroiditis. And you will find that most of these painless conditions, they all present to you in different phases clinically, hyper, hypo, or euthyroid at times, with goiter, without goiter. And on a radiological scan, that is a technetium uptake scan, all of these will give you the same picture of low uptake. So this is how we differentiate. All clinical pictures of hyper on radioiodine uptake studies or the technetium uptake studies will give you a low uptake picture. Now there are certain painful conditions. This also we very often come across. So there are painful thyroiditis, but they're easy to diagnose because pain is a very strong pointer that this particular condition is not a autoimmune Graves' disease. It is a passing phase, and the patient will soon end up with either a hypo or may even luckily become euthyroid. So this is a viral infective. This is a granulomatous subacute thyroiditis. Then there is a suppurative. Again, when there is suppurative, that is pus formation, it is non-viral mostly. It is bacterial, but it can be non-bacterial suppurative thyroiditis also. Then at times the patients are exposed to radiation because of some malignancies of the head and neck. Then it is radiation thyroiditis, or very rarely there can be trauma, and trauma can cause thyroiditis. So these are acute conditions, painful conditions, and all clinically presenting with either hypo or hyper. So these are the various types of thyroiditis that we come across. Acute mostly is infective. It can be suppurative, bacterial, or it can be viral. Subacute, again, it can be painful thyroiditis, that is De Quervain's that we studied long back in our ENT classes maybe. The De Quervain's thyroiditis. Then we have the granulomatous thyroiditis, which is mostly viral. These are viral thyroiditis, are mostly subacute in origin. If it is painless, then it can be either postpartum thyroiditis. Chronic are mostly the autoimmune, that is Hashimoto's thyroiditis, but it can also be Riedel's thyroiditis. Acute suppurative thyroiditis, being a viral and being a bacterial infection, not an autoimmune condition, has equal prevalence in male and female. It is usually preceded by an upper respiratory tract infection that leads to a painful enlargement of the gland associated with fever. The gland is swollen, tender, red, the typical signs of inflammation, and there will also be sign of abscess formation also. Subacute thyroiditis, it can be a painful or it can be a painless postpartum. Thyrotoxic phase followed by a euthyroid phase, or patient might stop there or may proceed to being hypothyroid. All thyroiditis pictures on radioiodine uptake will give you a low uptake picture. The treatment always remains symptomatic. We do not treat the antibodies. We do not treat the hyper picture. We just wait and watch. We give painkillers. If very severe, we might even require steroids. Antibody titers are high in autoimmune conditions, that is Hashimoto's. They can be present in postpartum also. At times, you will find antibodies are absent in viral or in suppurative thyroiditis. So subacute thyroiditis are usually the viral thyroiditis. They can be painful conditions. Again, you don't have to treat the hyper picture. Just treat symptomatically the fever, malaise, and soreness. Wait and watch. Might be the patient lands into a euthyroid status or might become hypothyroid for life. For the treatment of painful thyroiditis, again, it's a painkillers. You can use NSAIDs. Very severe and very toxic patients might require steroids. You can use beta blockers for the thyrotoxic picture, but please do not use anti-thyroid drugs. For the painless thyroiditis, again, the thyrotoxic symptoms at presentation, but there is no pain, no fever. Still, you treat them with beta blockers. And if SOS, some tired or fatigue picture is coming, you can use some paracetamol, but the anti-thyroid drugs are again not recommended. Postpartum thyroiditis, it's an autoimmune condition. Here again, the women passes through all three phases of hyper, hypo, hyper, euthyroid, and hypo. Then again, the hyper phase, you do not need to treat the patient with anti-thyroid drugs and just wait and watch. You can use the beta blockers. Propranolol is the most commonly used molecule. And if the woman becomes hypothyroid, then yes, you have to treat for life. If the woman ends up being euthyroid, then she's lucky enough. So subacute thyroiditis actually passes through the triple phase, that is a hyper, U, and hypo phase. This is how the picture looks like. Their gland becomes inflamed, and because of this inflammation, the membrane of the gland becomes leaky, and the hormones which are stored are released into the system. As a result, there's a rise in the thyroid hormones, which causes a feedback suppression of the TSH. And after a while, when these released hormones are metabolized and the gland is not working anymore, the gland is not in a mood to work, it becomes shrunken, it is atrophied because of the inflammation or because of the infection, and it is not producing any more hormones. The hormones in the system have also been metabolized. So now the hormones dip down, and as a negative feedback, again, this time the TSH starts rising. So there is a hyper phase. Then for a while, there is a euthyroid phase. When both the hormones become normal, it's a dipping phase. Very rarely the patients stop here, but mostly they land up into a hypo phase, and then they remain hypo and they are treated. And on treatment, then the patient becomes euthyroid and they need treatment for life at times. Hashimoto's is a chronic lymphocytic thyroiditis autoimmune condition and the most common cause of hypothyroid, the primary hypothyroidism nowadays. It's a common condition. affecting women more than men, almost to the tune of 9:1. Autoimmune in etiology. There is a diffused firm thyroid enlargement, and there is disruption of the follicular structure, and hypothyroidism is the clinical picture. To diagnose, you have to go for, of course, the biochemical workup, that is the TSH and T3, T4. More commonly, we are using FT4 and TSH. Antibodies, it is TPO antibody positive. Lymphocytic infiltration will be evident if you go for a FNAC. You can go for a USG, which will give you a firm enlargement of the gland. A thyroid scan is not required and it will not give you anything, no clinical picture, no clue. Patient mostly are either subclinical hypo or overt. Progressively, they become overt hypothyroidism. Now, Riedl's thyroiditis is another condition, which is a very rare condition, but again affecting female more than males. There happens to be fibrosis of the gland. And along with the thyroid gland, the adjacent structures are also fibrosed. So the gland becomes stony hard. And when you look at when you examine the patient clinically and you find a stony lump in the neck, you are very sure of your diagnosis that you are dealing with a very rare condition, that is Riedl's thyroiditis. But because of the pressure effect, it might even cause obstruction of the airways. There may be difficulty in swallowing. There can be even pressure on the larynx causing hoarseness of the voice. Clinically, the patient is hypothyroid. Also, this is interesting to notice that here, when the gland becomes stony hard, it also causes fibrosis of the parathyroids, and the patient is also hypoparathyroid. So there can be hypocalcemia and tetany at times. There are no regional lymph nodes enlarged, so you can differentiate with the cancers. When we take the class of thyroid malignancies, we can differentiate them that there are no lymph nodes enlargement. You treat them with steroids and tamoxifen, and most commonly the treatment is surgery. So this is about thyroiditis. So just an algorithm that how do we proceed? Suppose you are suspecting a thyroiditis. The first thing you have to look for is pain. Is it painful or painless? If it is painful and the patient is appearing toxic, then you are dealing with infective thyroiditis. If there is pain, but the patient is stable, then you have to ask for a history of radiation. If there is a history of radiation, CA, malignancy, head and neck, then you are dealing with radiation thyroiditis. If there is no history of radiation, no history of trauma, then probably you have to go for the biochemical workup and you find that TSH is raised, then yes, it is subacute thyroiditis. If the TSH is normal, but a normal, that is a euthyroid patient coming with a painful thyroid, then you have something called thyroid hemorrhage. So there has been some intrathyroidal bleeding. Now, if suppose the patient was having no pain, so it's a painless thyroiditis. In case of painless thyroiditis, you will have to find out the history of drug intake. If there is a history of drug intake, especially drugs like amiodarone, interferon, alpha interferon, interleukin 2 or kinase inhibitors, then it is drug-induced thyroiditis. If there is no history of drug, then you go for biochemical workup. On biochemical workup, if you find TSH is high and there has been a history of recent parturition, there is a case of postpartum thyroiditis, then yes, it's a case of but a high TSH and a history of delivery, then the woman was suffering from postpartum thyroiditis. If there is a high TSH but no history of delivery, then you go for antibody workup and probably you are dealing with Hashimoto's thyroiditis. If the TSH is low and a history of delivery is present, again, probably you are dealing with postpartum thyroiditis and the woman has been in the hyper phase, that is a thyrotoxic phase. So you can go for a scan, that is a technetium uptake scan, which will give you a low uptake to support your diagnosis of postpartum thyroiditis. If the scan gives you a high uptake, probably you are missing the diagnosis, you are dealing with Graves' disease. Now, if there is no history of delivery, no history of parturition, and you find that the TSH is low, you straight away go with a scan. And if the scan is giving you a high uptake, then we have Graves' disease. If the scan is giving you a low uptake, then we are dealing with a subacute thyroiditis, which is in the hyper phase. So this is about the thyroiditis. How do you approach autoimmune thyroid disorders? This is a fourth module. So if we have anything here to discuss, we can take it up right now. If we have anything to discuss in the autoimmune thyroid disorders, we can take it up right now. Or if we have no more queries, then we can right away begin with the fifth module, that is the hypothyroidism, which is scheduled for today.
Can I ask a question?
Yes, sir. Please, sir.
Certainly, there are different phases of this thyroid, but it will be very difficult. Suppose at a time person is hyper, and after some month or few weeks, it will be a euthyroid, or then it is hypo. So, how it will be relevant to use the, suppose if there is a hypo, we are using the thyroxine. So, it will be a kind of difficult picture for, suppose, a common practitioner to treat.
Sir, I think we are missing on some link. Mostly, if the patient is passing through the triple phase of hyper and euthyroid and hypo, then this journey is always one way. Very rarely it happens that the patient fluctuates from a hypo back to a hyper phase. If the patient is in a hyper phase and you can clinically detect by biochemical workup that the patient is having a low TSH and a raised T3, T4, and it is a phase of hyperthyroidism, you can go for a technetium uptake scan, which will give you a low uptake picture, which is typical of thyroiditis. In such a case, you have to wait and watch, repeat your biochemical profile in 6 to 8 weeks. The patient will either become euthyroid or the patient will become frankly hypothyroid. If the patient becomes frankly hypothyroid, please start the treatment with thyroxine replacement, as we will just study in the next module. And if you, once you start the treatment or euthyroid and make the patient euthyroid after your treatment, the patient will not fluctuate back to hyper. It will only happen with your iatrogenic dosing that the patient might again become hyper. In that case, of course, you have to down titrate your thyroxine dosing. But otherwise, the gland itself does not refluctuate back to hyperthyroid phase. So it's not very difficult to find out if the patient is in a hyper phase. You don't anyways treat, just wait and watch. After 6 weeks, if the patient is euthyroid, again, do not treat. Call the patient for a follow-up after, say, 6 to 8 weeks, another 6 to 8 weeks. Keep the patient under your follow-up for another 3 monthly or 4 monthly, 6 monthly, till the patient is very, very sure that now the euthyroid has been established and the patient is going to continue as being euthyroid without treatment, which is a rarity. Mostly, all thyroiditis make the gland atrophied and the gland really does not bring work back again. And you have to treat the patient with exogenous or external sources of thyroxine replacement.
Right, ma'am. Thank you. So you mean to say regular and stringent follow-up is required to see that either gland is inflamed or not. If it is inflamed, so let us that phase to be passed, painful or non-painful, depend upon that, and then accordingly you have to treat. Right, ma'am?
Very correct, sir. Painful, we interfere by just symptomatically helping the patient, giving some painkillers. Preferably, we are using indomethacin in cases of painful thyroiditis, which really works well in cases of thyroiditis. And we might even use some beta blockers for the thyrotoxic phase. In very bad patients, we might use even in suppurative thyroiditis, we might even use antibiotics. We might even require steroids if the patient is very, very, very toxic. And then, of course, the follow-up is not very frequent. We are following up the patient only once in 6 weeks, that is 1.5 months. So once in 6 to 8 weeks is the recommended follow-up period for thyroid disorders, because thyroxine hormones, they have a very long half-life. So they take time to shift their picture from a hyper phase to euthyroid phase to a hypothyroid phase.
Condition became very difficult. Suppose if patient has the other comorbidities like cardiac disease, where the amiodarone may be required, or with other drugs where the requirement is absolute, and they may affect the thyroid metabolism parallelly. So in that case, certainly the situation became very difficult.
There are clinical challenges. I'm not denying that, especially in cases of cardiac disorders, especially in patients with atrial fibrillations. If the patient has already been on amiodarone or needs amiodarone right at that moment. For example, if a patient lands up with thyrotoxicosis and that thyrotoxic picture makes him go into a flutter or a fibrillation, and the cardiologist decides to start amiodarone that point of time, then yes, there can be challenges. But then they are all individualized cases where we need to take the call according to the case.
Thank you, ma'am.
Right, sir. So any further questions or discussions?
Madam, good evening.
Hanji, good evening, sir.
Madam, thanks for having such a nice lecture. I want to know what is the significance of anti-TPO antibodies in a patient of hypothyroidism. What is the significance of its values, say 300 or 3000 in the diagnosis as well as in the management of the case?
Okay. Sir, that is very interesting to know, and it's a really very, very important question. Antibodies will tell you that you are dealing with Hashimoto's thyroiditis or autoimmune thyroiditis. This is one thing, that the antibody presence will tell you the diagnosis. One thing. Secondly, the level of antibodies is not something that we are chasing. We are neither treating them nor repeating them. We are not targeting them, and they are only done once to tell you that what is the underlying diagnosis, or if the patient is having an autoimmune profile. If the patient is having autoimmune profile, there are few things. One, that the patient is having autoimmune profile means there is likelihood of other autoimmune conditions to be present. Like in type 1 children, it can be type 1 diabetes as autoimmune condition. So the children can be having autoimmune hypothyroidism, that is Hashimoto's thyroiditis. These children can also have TTGA positive, and they can also have celiac disease. In adults also, most of the patients with autoimmune hypothyroidism, that is Hashimoto's thyroiditis, will also have maybe other autoimmune conditions, like there can be baldness, there can be other rheumatoid arthritis, or there can be other autoimmune conditions existing at the same time, or likelihood of developing other autoimmune conditions. But the level of the values of anti-TPOs or the values of anti-TGA, they are not very significant to treat. We are not chasing them. They just come down with time as the patient establishes a euthyroid picture by your thyroxine replacement. Neither we treat antibodies nor do we chase them for follow-up. That is the clinical standards.
Thank you, ma'am. I want to know one more thing, ma'am. There is a just a hypothetical case or a case. There is a say 28 weeks pregnant female, and her she wants her abortion to be done, and her TSH has come out to be 65. Now she has come from PAC, and PAC people have said that surgery, she cannot undergo MTP, reason being very high TSH. Now, what are the requirements for her to become fit for surgery, and in case of hypothyroid, and otherwise she was completely asymptomatic in spite of TSH being such high levels, 65.
So just if you don't mind, can you just repeat your gestational week?
8 weeks.
Okay. So it's just an early pregnancy, first trimester pregnancy.
And she wants MTP for that.
That's fine. Then I got your point. First of all, let me make one thing clear. We are not recommending MTP because of thyroid.
No, she was not wanting MTP because of hypothyroid, but she was wanting MTP because she already has.
I get your point. I'm just making it clear once again, just repeating it just for everybody to understand that whatever the TSH value, it should not go, the message should not ever go that because of the TSH value or hypothyroid status, we are recommending a termination of pregnancy. So that never happens. So if she's not going for termination because of thyroid, she wants a termination because of her own reasons, and then incidentally it happens that she has come out to be a primary hypothyroid with a TSH of 65. So one thing is, even if we start her treatment right away, the pregnancy will continue for another week or so if we are asking her to wait for the termination of pregnancy, because TSH 65 is a pretty high TSH where we will not allow any surgery. And for MTPs, one procedure at 8 weeks, I'm not a gynecologist, but I'm very sure of this much, that 8-week pregnancy can be taken for a termination. It does not require a major surgery. But if you talk of any other major surgery, then it has to be stopped. It has to be held back till at least the T4 or free T4 becomes normal. And that will require at least 7 days to 15 days to become FT4 to become normal. TSH will move very slowly. To bring TSH from 65 to a normal value of less than 3.5, maybe it will require 6 to 8 weeks. But For FT4 to move, because the thyroxine hormone moves faster. So for FT4 to move, it will require it will require 2 weeks. So if it is a surgery that can be postponed for 2 weeks, then elective surgeries are always postponed. If it is an emergency surgery that cannot be postponed, then of course the surgery has to be taken up with caution, and maybe we can give a backup of steroids, or maybe we can give a backup of thyroxine replacement on a higher dose. But that even if you go for a higher dosing, it will require at least 7 days for the thyroxine to normalize. So emergency surgeries are always taken up with a high risk consent, but elective surgeries are postponed until the patient is euthyroid.
Yes, ma'am. In spite of 3 weeks of thyroxine in the dose of 200 micrograms, the TSH is again 25. After 3 weeks of thyroxine, 150 micrograms. Now, what to do? Because the further we delay the MTP, further it would be more complications later on may come up.
You
So
may not delay, sir. You may not delay the MTP. Just assess the FT4, because TSH will take time to come from 65 to normal, but FT4 will normalize within 2 weeks.
So if FT4 is normal, then we can undergo make the patient fit for surgery.
Yes, sir. Because the bioactive molecule is FT4 and FT3. So if your free hormones are normal, you can give a consent for surgery.
Okay, thank you, ma'am.
So we have anything more to discuss here? Okay, so Dr. Prakash sir, can I take up the next module?
Yeah, this is the right time. We should move for the next module.
Right.
It was a very good discussion and informative.
Thank you, sir. So now we come to hypothyroidism. Before I begin with hypothyroidism, let me give you a very beautiful description of hypothyroidism by Osler. So Osler said, there is a marked increase in the general bulk of the body, inelastic swelling of the skin, that is a non-pitting edema, dryness and roughness. Perspiration is often much decreased. So there is cold intolerance. The features are coarse and broad, the lips thick, the nostrils broad and thick, the mouth is enlarged. There is striking slowness of thought and movement. The memory becomes defective. The patient grows irritable and suspicious, and there may be headache. In some instances, their gait is heavy and slow. So this is a typical symptomatology of hypothyroid patients. Though that is a condition that actually happens when they are significantly hypothyroid. So hypothyroidism can have multiple etiologies. The underlying defect is there is low thyroid hormones. So low thyroid hormones can be either because of the gland defect, that is primary hypothyroidism, or the defect lying at the hypothalamic or at the pituitary level, that is secondary hypothyroidism. But besides these primary and secondary, there can be other causes of dysharmogenesis. So that is anything which causes decreased thyroid hormones that causes hypothyroid picture. So we discuss hypothyroidism in 3 age groups, maybe the adults, children, and pregnancy. The pregnancy and children we will not be taking here, because pregnancy thyroid disorders will be a different module which will cover hyper, hypo, and other picture of pregnancy disorders. And children will also be covered in just touch through, because we are not into pediatric practice, all of us. But still, I will just touch upon the hypothyroid picture in children when I talk of pregnancy disorders. So for today, we will be talking of hypothyroidism in adults. So hypothyroidism in adults, when we talk of, it can be a primary hypothyroidism when the disorder is at the thyroid level. So it is most commonly, as we discussed, autoimmune thyroiditis, that is Hashimoto's thyroiditis. There can be congenital absence of the gland, that is a neonatal picture when there is congenital gland absence, defect in the thyroid hormone itself, the gland itself is absent. There can be also defect in the thyroid hormone synthesis. Then there is surgery, post-surgery, because of whatever reasons, it can be malignancy, it can be other issues, that the gland has been removed. There can be radiation, that is radioablation of the gland. So whatever the reasons, it is the gland defect lying at the glandular level. So there is thyroid dysfunction. At the same time, you find that there is iodine deficiency, which is now a rarity, but there were times when iodine deficiency was a very important diagnosis. Then there can be congenital enzymatic defect, that is dyshormonogenesis. It can be drug mediated, especially amiodarone, lithium, and thionamides. So they are the causes all leading to primary hypothyroidism. If the gland is absolutely normal and the defect is somewhere at the hypothalamic or at the pituitary level, that is defect in TRH or TSH secretion, then it is called as secondary hypothyroidism. It can be because of the tumors lying at the hypothalamic region, that is lymphomas, germinomas, gliomas. There can be infiltrative disorders like sarcoidosis, hemochromatosis, or histiocytosis. There can be pituitary disorders like Sheehan's, that is postpartum hypopituitarism, or it can be lymphocytic hypophysitis. This is another very important and interesting picture when you find a vanishing pituitary. The patient had presented with a mass and then a repeat MRI after 2 years shows there is empty sella. So they are vanishing pituitaries. Then pituitary tumors can be there. There can be craniopharyngiomas, there can be prolactinomas, there can be GH secreting tumors, and of course there can be cranial irradiations causing again empty sella, that is a pituitary destruction. So all these things that are where the thyroid gland is innocent, but there is defect at the hypothalamic or the pituitary level is the secondary hypothyroidism. Now, what are the hints? How can you clinically think that which patient can have what? Age of the patient. Aging leads to declining thyroid functions. If there's a goiter, then of course there's something to do with the gland. OBS history, recent OBS history might give you a picture of either a postpartum thyroiditis or a picture of Sheehan's. Drug history will give you a drug-induced either thyroiditis, which is hyper or hypo. Then comorbid conditions, that is coexisting other hormonal disorders, if there is existence of multiple pituitary hormone defects. So other hormonal disorders will be a clue. Or if there are other autoimmune conditions present, like vitiligo especially if present, is a pointer that this patient will have autoimmune hypothyroidism. Now the symptoms of the symptomatology, beginning with neurological symptoms like fatigue, tiredness, depression, loss of memory, difficulty in concentration, paranoid symptoms. Patient can have madness, myxedema madness, which is very extreme conditions. There are tingling, numbness, paresthesias, and slow tendon reflex. Now, this was one of the markers of hypothyroidism. When there was a hanging reflex, the hanging knee reflex that we used to study. Then the GI symptoms, there will be slurring of speech because the tongue is enlarged. So enlarged tongue, difficulty in swallowing. This can be because of the mass effect of the gland and also because of the difficulty in swallowing because of the enlarged gland also. Then there is constipation. Constipation is almost synonymous with hypothyroidism. Whenever a patient complains of constipation, we invariably assess the thyroid functions because this is almost vis-a-vis synonymous with hypothyroid picture. So mostly the reason is that there is a slow GI motility. The motility is affected. Musculoskeletal, again, there is stiffness, pain, muscle pains, there can be cramps. Skin findings, there will be drying of skin is most common. Then cold intolerance is there, decreased sweating is there, hair texture is altered, there's drying of hair, hair fall is a very common presentation, loss of the lateral 1/3 of the eyebrows, nails are very brittle, there are voice changes, there is hearing impairment. All these are symptoms of hypothyroidism. There can be difficulty in conception, difficulty in carrying the pregnancy. There can be delayed pubertal development, especially the height attainment in children is affected. So the children are short. Short, obese children are a landmark markers towards an underlying endocrine disorder. If a child is having a normal height growth with weight gain, you can just clinically refuse there is no endocrine disorder involved. If there is endocrine disorder involved in the growth, then the first marker is height is arrested. So if the child is having a delayed puberty, delayed height attainment, then we are thinking of hypothyroidism. There can be delayed menarche, but in women who are already having their cycles established, there is menorrhagia. Delayed cycles or short cycles are a picture of hyperthyroid. Hypothyroid women mostly present with menorrhagia or short cycles and heavy bleedings. There can be high prolactin causing galacturia, and because of this, there can be infertility. Males might present with decreased libido, impotence, blood vessels are affected, there will be bradycardia, there can be low voltage ECG, there is diastolic hypertension, even there is diastolic dysfunctioning on 2D echo, there will be exertional dyspnea, and there can also be pericardial effusion. Hematologically, you find anemia, and this time it is a macrocytic anemia. There can be pateshi, there can be bruises, difficulty in respiration because the lung capacities are decreased, there is hypoventilation, there is dyspnea, and there can be pleural effusion. This is again very important because you get so many references you will get from ICU. Kindly evaluate the patient for euvolemic hyponatremia. So what are the common causes of euvolemic hyponatremia? After you rule out syndrome of inappropriate antidiuretic hormone, that is SIADH, the two more common causes, endocrine causes of euvolemic hyponatremia is either hypothyroid or hypocortisolism. So you have to rule out hyponatremia. If there is hyponatremia, you have to rule out hypocortisolism and hypothyroid. Then there can be hypoglycemia and there can be hyperuricemia. Lipid metabolism is altered, so the patient will have increased triglycerides, increased LDL, there will be hypercholesterolemia. So this is about the symptomatology or the pointers towards an underlying hypothyroid disorder. Hypothyroid facies, as we understand, we have all gone through the Osler's description. There will be a swollen face, a yellow skin. There's a yellowish skin because of the carotenemia. There's hoarseness of voice. The patient will smile, but that smile takes time to come and slowly it will happen over the face. So specifically hypothyroidism, if you are thinking of, there can be resistant anemia, menorrhagia, high cholesterol, high prolactin, pericardial effusions, impotence, alopecia. Depression is a very important finding, and the patient is almost not with there. Physically, the patient might be present, but patient is just lost. He or she is not present psychologically, emotionally, or mentally. The patient is not there. There are vague muscle aches and pains. So this is about the clinical picture. So you ask for a lab workup, and the lab workup comes out to be the low thyroid hormones. The T3, T4 are low and a rise in TSH. That is a typical picture of primary hypothyroid. If it is a secondary hypothyroid, you will find a low T3, T4 along with a low TSH. Now, just remember here this much, that not necessarily that the T3 may be low, because T3 is a result of peripheral conversion from T4. So quite late, T3 remains normal. It is mostly the T4 which is reduced, and it is the T4 which sends signal to the pituitary and the hypothalamus to release TSH. So there's a rise in TSH and fall in T4, but the peripheral normal values of T3 are maintained till quite some time because T3 results from peripheral conversion and that is maintained. But ultimately in the later stages, even T3 is low. Antibody profile can be positive, and in secondary cases, all will be low. So this will be a biochemical picture. You might ask for some more tests, which may not be of any significance directly, but indirectly they will tell you things like to treat or not to treat, like there will be dyslipidemia, there will be some derangements of AST, LDH, there will be some anemia. ECG might show you lower voltage complexes with bradycardia. There can be pericardial effusion, so you can go for 2D echo. Now, do not jump to treat with statins or antihypertensives or diuretics or the hypouricemic drugs till you have not made your patient euthyroid. So first make the patient euthyroid, allow the patient to remain euthyroid for a period of say at least 2 to 3 months, that is 12 weeks, 6 to 8 weeks, 12 weeks. And after 12 weeks, if the repeat picture gives you a rise in cholesterol or the uric acid, or if there is edema still present, blood pressure still present, then introduce statins or antihypertensives, but do not begin the treatment from here. So what are the treatment options? Of course, we all have so far, though we are very soon going to have T3 with us, But so far, we all have only levothyroxine available. So what is the treatment option? Only one so far, that is levothyroxine. Of course, there are T3 available in some gray markets. I have that information, but I'm not using it. Maybe if we are using, we can discuss. But soon it will be available. Abbott is going to come out with T3 very soon. Dosing, yes, that will we will discuss how do we dose and how do we up titrate the dose and how do we down titrate the dose. What time we take the molecule, how frequently, and what are the targets. So treatment options are many. Initially, we had desiccated thyroid. We can use thyroglobulins, the synthetic mixtures, or even T3. But so far, we are only using levothyroxine. Levothyroxine preparation is available right from 12.5 micrograms to 25, 50, 37.5, 88, 150. So up to 150 and even up to 200 micrograms levothyroxine preparations are available. So why don't we use T3 and why don't we use combinations? Why we are not having T3 still in our with us? The reason being that T3 has a very short half-life. So you require multiple daily dosing, 20 micrograms BD or TDS you will have to prescribe. Again, that will give you a lot of fluctuation because after dosing, there is an initial jump in the T3 levels and then the levels will drop. So the fluctuations will be more with T3 dosing. As a result, we are not using T3. Then, of course, the combination that some part to T4 and some part T3 is again very confusing picture. So it is not easy to understand all this combination, permutation combination. So the easy game was to use only levothyroxine. Desiccated thyroid, we are not using. The very old times it was used, but now we are not using it at all. So the latest recommendations are that continue to use levothyroxine. And the only part is that we still have only oral formulation with us. So even in cases of emergencies, as one of the attendees here were just discussing, that even cases of emergency surgeries, we do not have something called injectable levothyroxine or IV levothyroxine. So levothyroxine therapy is preferred because it's a stable molecule, more physiological, and it gets converted peripherally into T3. So what are the dosing? Now, dosing depends upon many things. One is your age, second is your body weight, and third is your level of TSH. So there are three important things. So we preferably begin from the body weight. We begin with body weight, that is 1.6 micrograms per kg body weight, but we also keep in mind the age. If it is a gentleman of 70, 80 years, I will keep it on the lower side, maybe 1 microgram per kg body weight. If he is a gentleman or a lady of young age, around 30, 40, 50 maybe, I can start with a full dose of 1.6 microgram per kg body weight. If there is an existing comorbid condition, again, I will go for a lower dosing to start with. If it is a case of subclinical TSH, again, I will start with a lower dosing. So it has to be individualized. There has to be some range. So you can choose the low normal range for your patients who are more at risk. You can choose the high normal range when you are choosing for patients who are with less risk. So what are the factors that determine? Determining factors are either the etiology. Etiology is important. I will tell you how. Then adherence to therapy. How good is your patient with compliance? What is the BMI? What is the lean body mass? Then age, of course, is important, and gender. The women, especially the premenopausal women, they require a little higher dosing. Then, of course, the comorbid conditions. If it is a CAD patient, elderly patients, you use a lower dosing. If it is a cortisol deficient patient, then first replace the cortisol. Let the body come and have a eucortisol status. Otherwise, if you jump start the metabolism with levothyroxine, your patient will land in an adrenal crisis. Then, of course, the severity of hypothyroidism. If the patient is severely hypothyroid and you are little in a hurry to establish the euthyroid status, then of course you start with a slightly higher dosing. So what are the timings? Again, ideal time is early morning, empty stomach, because it's a hormone, it's a peptide, and it's a hormone which is very sensitive. The absorption is affected. It wants acidic media to get absorbed, and the acidic media of the stomach is not altered without disturbing this acidic pH. Early morning, empty stomach, the first thing you do is take your tablet and allow 30 minutes for the drug to get absorbed or to move down to the jejunum and ileum where the absorption actually occurs. But again, there are pros and cons. There are people who will suggest you can take it at night, bedtime. That is a second best option. Yes, you can take it at night after your dinner, 2 hours after your dinner, just before you sleep, because that will allow the drug to get absorbed overnight. Another less good option is you take the drug early morning and wait for something at least for 30 minutes. If you can wait for 60 minutes, that is the ideal time. If you are taking it just before breakfast, again, the bioavailability is questioned, but these are the various ways that you take it. Now, food interferes by decreasing the pH of the stomach. High fibers and soya, they are not recommended along with your drug. Coffee, tea, again, because of the binding with the molecule. Medicines like, especially the proton pump inhibitors, because half of our population is in the habit of taking a PPI early morning, empty stomach, either they are eating pantoprazole or rabiprazole. So this is one molecule which has to be stopped. So all medicines like calcium, aluminum containing antacids, iron, cholestyramine, even your PPIs, they all interfere with the absorption. So they are not recommended to be taken along with the molecule. So ideally take it early morning, empty stomach, and do not take at least 60 minutes anything after the tablet. Or second option is you can take it bedtime. At least keep a 30 minutes fast over the tablet. And a very less likely chances, okay, if you've completely forgotten, take it before your breakfast at least. So what if a dose is missed? Again, we have varying options here. Some suggest their patients to take double dose the next day, because thyroxine is a long-acting molecule. Even if you take the 7 days preparation together, it does work. So if you want, you can recommend your patient that they can take all 7 days tablet on single day. The only problem here is that the patient, if misses that 7th day also, then that becomes a challenge. So ideally, we recommend take it every day without forgetting, because if you allow them to double the dose second day, they might do it the 3rd day also, 4th day also, and then that becomes a habit, and ultimately the dosing becomes erratic and irregular. So we have 2 frequencies available, either daily or weekly, but we are still, weekly was very much in fashion in between, but now again we are back to daily dosing. It was various data have shown that yes, weekly dosing is allowed. They can be taken, especially in patients who are very bad at compliance and adherence. You can ask them to take it every Sunday, but if they forget on Sunday also, then it will be 2 weeks time, and then again it will be an erratic dosing. So the idea is only to ensure compliance. Now, how do we monitor the dosing? We monitor it first whenever you are making a change in the dose, then monitor it at 8 weeks. If you're introducing the molecule new or you're changing the dose, repeat after 8 weeks. If you are not making any change, the patient is stable, then you can repeat it after even 6 months. Okay. If it is a case of secondary hypothyroid, there is no further role of TSH. You have to monitor only FT4, and FT4 moves fast. So you can monitor FT4 even every 2 monthly, that is 8 weeks. So what are the targets? The targets are to achieve euthyroidism biochemically and clinically. So biochemically, the lab tests, and clinically, of course, the patient will tell you that he or she is doing good. So important pointers are always start with a slow dose in older patients and patients with ischemic heart disease. In elderly patients, geriatric population, IHD patients, up titrate slowly. Patients with thyroiditis, again, you do not need to treat initially till you establish a hypophase. If they end up in a hypophase, then you have to start your treatment. And this thyroiditis might be again progressive. So you have to monitor your dosing, and the dose might go on increasing. During pregnancy, we don't have this slow titration time. So we start with full dose, and we in fact give additional 25% raise in the dosing because of the fetal requirements. And we monitor also very frequently in pregnancy, every 4 to 6 weekly. If there is a cortisol deficiency coexisting, make the patient eucortisol first. So this is about hypothyroidism. One word about subclinical hypothyroidism. Subclinical hypothyroidism is a term when you have a TSH on the lower side than the cutoff to label as a primary hypothyroid, but it is on the higher side still than the normal. That is somewhere between 3.5 to 10. If the TSH is somewhere between 3.5 to 10, that is subclinical. That means there are no clinical pointers. Patient is asymptomatic. Now, this patient can progress to hypothyroid or can remain subclinical or may revert back to a euthyroid picture that is unpredictable. If the patient is, and here comes the role of antibodies. If the patient is autoimmune, if it is a case of autoimmune hypothyroidism, there are TPO antibodies positive, then these patients are very likely to progress to clinically overt hypothyroid. But if the patient is having antibody negative and the patient is obese, maybe with weight loss, they become euthyroid. If the patient is having normal weight, then also these patients might become euthyroid with improved metabolism, or they might progress to hypothyroidism over a period of time. So subclinical hypothyroidism do not merit treatment always. You have to decide individually when to treat. How does subclinical hypothyroidism is important? Because the damage at the cardiac level is still going on. Damage at the lipid level, the lipid metabolism is still affected. So these are the patients who will have cardiac functions deranged. They will have high LDL, they will have high triglycerides, and they will be hypertensive. So these are the pointers that you need to treat subclinical hypothyroidism. Rate of progression is unpredictable. It is 3 to 18% every year. So the risk profile is something like this. The older the patient, lesser is the risk, and you do not need to treat the patient. The younger the patient, the risk is more, and you need to treat the patient. So subclinical hypothyroid, if the TSH is above 10, treat. If the TSH is below 10, antibody is positive, treat. If the TSH is less than 10 and antibody is negative, just follow up. Women requiring fertility, treat. Children requiring gain in height, treat. Adults above 70, do not treat. So these are some clinical guidelines for subclinical hypothyroidism. Surgery in hypothyroid, we just discussed already. Make the patient euthyroid before going for elective surgeries. For emergency surgeries, you have no options. So for elective surgeries, wait till the patient is euthyroid. For emergency surgeries, please carry on with high risk consent. For myxedema, we still do not have any IV preparations in India. So we have to just treat as we are treating, keeping the dosing slightly on the higher side. So typical pictures of myxedema will be a hypothermic, hyponatremic, hypotensive patient, hypoventilating, requiring ventilatory support. There can be neuropsychiatric manifestations and there can be infections, but there may not be any fever because the patient is already having cold intolerance. So I think this is 3 o'clock and my time is over. So with that, I end my class. Thank you so much for being here this afternoon, Sunday afternoons. Prakash sir, all yours.
Thank you, Dr. Minal. Really, it was a very nice presentation and very well presented, given all the types of hypothyroidism, presentation of the hypothyroidism and how to treat pregnant hypothyroid children and other comorbidities. It was a very good, well presented. And now we move towards the second session of the day, that is for the male hypogonadism. And I think Dr. Shyam Sundar sir is also have joined. Sir, have you online?
Yes, I am.
Thank you, sir.
Can you say a few words to motivate all the speakers and the participants?
Dr. Keshwani, Dr. Mittal, and friends. It's really, I have been seeing this certificate course for almost 3 weeks now. And the hypothyroidism and or thyroid disorders as well as the gonadal disorders are quite common. I mean, everyday practice when the physicians come across. So it is very important that these courses are held frequently. And really, the speakers are wonderful. And you just saw the lecture on thyroid, hypothyroidism by Dr. Minal. It was really a fantastic lecture. So now we have a lecture from the director of my institute, Professor Dr.S.K.Singh, who happened to be my student as well. So it is really a great pleasure to be here. And I wish this program a great success. Thank you very much.
Thank you, sir. Thank you for your nice words. Now, our next speaker is Dr. S.K. Singh, who had been my teacher while pursuing DM. And at present, he is Director of Institute of Medical Sciences, BHU Varanasi. And he is also head of the Department of Endocrinology and has been a guide to many of the DM students. He will be speaking on the diagnosis of male hypogonadism. He has a real research work on the diagnosis of male hypogonadism. I invite Dr. S.K. Singh, sir, to please share the screen. Dr. S.K. Singh, sir. Dr. S.K. Singh, sir. हाँ सर, नहीं तो स्लाइड्स मेरे को आप भेजेंगे तो मैं उसको अजय को बोलूंगा तो वो कर देगा. हाँ सर, मैं उसको अजय को भेजता हूँ सर.
Sir, if it is taking a minute or so, and there are 2 questions in the chat box, can I take them?
Yes, meanwhile we can.
So there are 2 questions in the chat box because till Dr. S.K. Singh sir puts up his slides. One question is very important, and that says about what happens if the patient is euthyroid, should we down titrate the dosing? So this is very important. Geeta ma'am has put up that we have to understand that once the patient is euthyroid, you have to continue with whatever the dose the patient has become euthyroid on. Euthyroid establishment and assessment only makes sure that the dosing is now the right dosing for the patient. It does not mean that the patient's own gland has started functioning and the patient is now euthyroid because of his or her own gland. So once the patient is euthyroid on whatever dose, please continue with the same dosing. It is only if the patient has become iatrogenic hyperthyroid or maybe subclinical hyperthyroid that you down titrate the dosing. Otherwise, once you establish a euthyroid status, please continue the same dose. Another question that has been put up by Dr. Das Munshi is that in rural scenarios, in the rural setup, we do not have the 99 technetium uptake options. In such cases, how do we decide whether it is thyroiditis or whether it is thyroid hyperthyroid because of autoimmune conditions? So do we start the anti-thyroid drugs or we do not start the anti-thyroid drugs? Dr. Das Munshi sir, this is again very important, clinically very, very relevant, because if it is autoimmune thyroid dysfunctioning, that is Graves, there has to be some markers of Graves ophthalmopathy, or there will be some markers of Graves dermopathy. If there are no markers of clinically dermopathy or markers of ophthalmopathy, then another important point is a family history. If you find there is a family history of thyroid dysfunctioning, then that is a pointer towards autoimmune dysfunctioning. If there are no family history also present, then there is a third very subtle marker, that is your thyroid biochemistry. In Graves' disease, you will find that the level of hormones is markedly high. Whereas in cases of thyroiditis, the level of hormones is above the normal range, but they are not very, very high to cause a severe hyperthyroid picture, the toxic picture. So if the patient is toxic clinically with no family history, with family history positive and with markers of ophthalmopathy or dermopathy, you start with anti-thyroid drugs. But if there are no markers, no family history present, and there is just a borderline rise in the T3, T4, and a borderline suppression of the TSH, then maybe you are dealing with thyroiditis. If the patient is giving a history of fever, pain throat, or a URI, then again it's a marker of thyroiditis. So you can take a chance, wait for 4 to 6 weeks and repeat the biochemistry. So these are some clinical pointers, sir. Keswani sir, you are muted, sir.
Something is when there are no clinical markers, as you told, and T3, T4 are borderline or elevated to some extent. Sometimes TSH helps. TSH, if it is only reduced less than normal 0.04, 0.3, 0.2, then we have to think of sometimes thyroiditis. And it is in hyperthyroidism, it is usually suppressed to less than 0.01.
Yeah.
So sometimes it may help.
Yes, sir.
And of course, clinical presentation like reduction of the body weight and all these. And in rural settings also, this can help. The clinical markers, if are present, they help in managing these patients. Dr. S.K. Singh is not able to share screen with the slides. So I think Dr. S.K. Singh, sir. हाँ सर, हाँ सर, बिल्कुल सुन रहा हूँ सर.
Hello? Hello? Prakash, you are muted. Prakash, you unmute yourself.
Good afternoon,
Yeah.
sir. We are waiting for you.
Good afternoon. Yeah, good
Yes.
afternoon.
Dr.
So,
Shamsundar sir was also on the line and was asking, saying that director of our institute is going to talk on the male hypogonadism. So,
yeah,
sir,
yeah.
we are eagerly waiting for you. As
yes.
introduced earlier, Dr. S.K. Singh had been my teacher while pursuing DM, and at present he is director of Institute of Medical Sciences, BHU, and head of the Department of Endocrinology for last so many years, and have been guide to a number of DM candidates. I invite Dr. S.K. Singh sir to please start your talk on the male hypogonadism, on which topic you have original work also. So Dr. S.K. Singh sir, please enlighten us with this topic.
Okay, thank you, Dr. Prakash, and thank you everyone giving me this great opportunity to interact with you online, saving a lot of time. And my teacher, Professor Shamsundar, is also part of this program. I'm very proud to be associated with him. The assignment given to me is diagnosis of male hypogonadism. Are you able to see my slides? Okay. Right. So in next 20 minutes, I would take you through this important aspect. And I would also share the late onset hypogonadism that is of major concern than in general male hypogonadism, which is largely related to endocrinologists. So first of all, when we need to diagnose hypogonadism, we must know what is the definition of hypogonadism. And there had been various definitions for hypogonadism. One is that by the European Association of Urology. And this is the most appropriate definition of male hypogonadism, that it is a clinical syndrome caused by androgen deficiency affecting multiple organ functions and quality of life. But this is comprised of two major components. The first is the persistent clinical symptoms, related to biochemical evidence of testosterone deficiency. So when we have biochemical evidence of testosterone deficiency reflecting the clinical symptoms, we usually make a diagnosis of male hypogonadism. The International Society for the Study of Aging Male has slightly different definition for hypogonadism, and that is mainly related to adult onset hypogonadism, which is an adult man is a clinical and biochemical syndrome associated with low level of testosterone, which may adversely affect multiple organ function and quality of life. In this definition, one important component should be added, that is not only testosterone deficiency, but also the effect of testosterone is not there, that is called androgen insensitivity syndrome, and that also becomes part of male hypogonadism. And etiologically, this can be classified as primary. Primary means testicular deficiency or testicular defect. Secondary, because of hypothalamic failure or hypopituitarism, and there could be a combination of testicular failure as well as the hypopituitarism together. So all these are taken into account while trying to make a diagnosis of male hypogonadism. We can have variety of underlying causes, and we should remember when we are investigating male hypogonadism. The most frequently observed cause of hypogonadism are isolated or idiopathic hypogonadotropic hypogonadism, that is a garden variety of Kalman syndrome. Then we may have a hypopituitarism, which is a combined pituitary anterior pituitary hormone deficiency. We can have Klinefelter syndrome, which is mainly related to extra X, that is XXY syndrome, and there is a functional hypogonadism. So we can classify hypogonadism as primary when there is a testicular defect, as secondary when there is a hypothalamic defect, as functional hypogonadism, which occurs mainly due to pituitary defect, or there could be other hormone increase that inhibits release of anterior pituitary hormone, mainly hyperprolactinemia or hypopituitarism occurring primarily because of pituitary defect or pituitary surgery. Then there could be target RN resistance, and this is mainly due to androgen receptor abnormality or androgen biosynthesis defect, mainly the 5-alpha reductase deficiency, which converts testo into very active testosterone. And if there is a 5-alpha reductase, they will present with hypogonadism. Functional hypogonadism is closely linked to obesity and underlying conditions. So a functional hypogonadism is a state of defect in the pituitary function, and this is very commonly seen in obese individuals after age of 50. Aging is another component, or aging is another factor that leads to functional hypogonadism. There is a defect in the gonadotropin release with advancing age, and this is further enhanced by obesity. So if somebody has obesity and advancing age, there is a more chance of having functional hypogonadism. There is increasing evidence suggests that in these men, low testosterone is due to functional hypopituitarism or hypothalamo-pituitary testicular axis suppression. This is very good cartoon showing there is a very strong relationship between the testosterone level and the body mass. If you have more fat in your body, the testosterone level is low. And if you reduce the fat by bariatric surgery, there would be increase in the testosterone level. So this study very clearly indicates there is a strong association between body fat and the testosterone level. Higher the body fat, less is the testosterone level, and that is very common problem in aging male. Hypogonadism or testosterone level declines with age, and this cartoon is showing that each decade increase in the age, there is a fall in the testosterone level. Both the low total testosterone as well as bioavailable testosterone, both are influenced or affected by advancing age, which you can see in this cartoon. So we must remember where to investigate, when to investigate for male hypogonadism. If you remember the symptoms and signs which are suggestive of male hypogonadism, this is very easy to target at for making diagnosis of male hypogonadism. The clinical symptoms and signs are reduced testicular volume, male factor infertility, decreased body hairs, gynecomastia, loss of energy, decrease in the body mass or muscle mass, sarcopenia, obesity. Metabolic syndrome, insulin resistance, and type 2 diabetes has also been linked with development of male hypogonadism. Decrease in the bone mineral density, if somebody has osteopenia or osteoporosis in male, that indicates presence of hypogonadism. Mild anemia, which is very difficult to treat in most of these patients, that also indicates male hypogonadism. Reduced sexual desire, erectile dysfunction, fever or diminished nocturnal erections. Cognitive and psychovegetative symptoms are also attributable to androgen deficiency, hot flushes, change in the mood, sleep disturbances, depression, diminished cognitive function, and many of these males, they lost interest in their environment, and that also indicates presence of male hypogonadism. Most of our diabetic patients and patients with metabolic syndrome are actually having these problems, but that remains largely unrecognized because we think that it is not that common to see late onset hypogonadism. But this does occur, and there are many studies indicating presence of male hypogonadism in diabetic population in patients with metabolic syndrome. So clinical assessment of testosterone deficiency syndrome includes symptoms and biochemical confirmation with low circulating testosterone concentration. Rarely testosterone insensitivity that indicates that is there with the clinical features and high testosterone level, with the LH gonadotropin level also on higher side, that indicates testosterone insensitivity. The most widely accepted diagnostic parameters for male hypogonadism are serum, total testosterone, and free testosterone. Clinical consequences of hypogonadism are determined by the age of onset and severity. If it occurs in utero, there will be problem in development of genitalia, and they present with the DESD, that is disorder of sexual development, usually seen with testosterone deficiency in 9 to 14th week of pregnancy. Lack of insufficient testosterone exposure in the latter phase of development leads to penile growth or micropenis, not the sexual differentiation problem. So DSD is not seen if testosterone deficiency occurs after 24 weeks or after 16 weeks. The clinical consequences of hypogonadism are determined by the age of onset and severity, and this is the androgen deficiency during puberty. If it occurs during puberty, there would be delayed puberty, small testes, there may be cryptorchidism, gynecomastia, high pitched voice, unclosed epiphysis, or delayed bone age. Linear growth into adulthood is retarded. Inacquired body habitus, sparse body hairs, infertility, low bone mass, sarcopenia, reduced sexual desire. If it occurs at time of puberty, and if it occurs after puberty, with onset after puberty, the clinical picture of hypogonadism can vary widely depending on the severity of testosterone deficiency. Body proportions, penile size, and pitch of voice do not change with the testosterone deficiency occurring in adulthood. Body and facial hairs reduce. Other clinical features are decreased sexual potency, loss of libido, and infertility, and I've already enumerated them in the previous presentation. This is one study we actually suggested through our small study in the patient group. Hypoandrogenemia could be a component of metabolic syndrome, and what we have demonstrated that people with metabolic syndrome have lower level of testosterone, and you can see they have high level of sex hormone binding globulin, and there had been very good correlation between the sex hormone binding globulin and insulin resistance. They have sex hormone binding globulins high, and therefore the free testosterone is low. So even they have a testosterone in normal range, they still have testosterone deficiency because free testosterone is in lower range. And we can measure free testosterone, or we can derive it through formula, bioavailable testosterone. There are some formula which are available, and the most important one we use is the mathematical formula to determine the free testosterone. Evaluation of hypogonadism and effect of clomiphene citrate in patients with diabetes. What we have demonstrated that those who have evidence of low testosterone with normal LH, that suggests that there is a evidence of hypogonadotropic hypogonadism in obesity, and therefore they could be benefited by any measure that increases the gonadotropin level, testosterone will rise and they will respond. And our paper actually was presented in one of the IDF meeting that patients with diabetes mellitus, they have a higher chance of hypogonotropic hypogonadism, and they do respond to clomiphene citrate, which is anti-estrogen, and thereby it increases gonadotropin and raises the testosterone level that we have demonstrated in this study. Clomiphene citrate being quite safe in doses we have used, that is 25 milligram every day for 25 days every month for 3 months. And we demonstrated there is a rise in the testosterone level. So we are actually, myself, I'm using clomiphene citrate in some of my patients who have some evidence of hypogonadism and their testosterone level is in low normal range. Very low level of testosterone, like if they have a low hypotestosteronemia, in those cases, we have to treat with testosterone replacement. So biochemical examination of adult man with suspected hypogonadism, we must measure the LH-FS and total testosterone. That might help if the total testosterone is low and LH is high. That suggests primary testicular failure. If LH is normal range with low testosterone, that suggests hypogonotropic hypogonadism. And if it is quite low LH and testosterone, that clearly indicates some pathology in the pituitary responsible for hypogonotropic hypogonadism, and this is not functional hypogonadism. We have a problem in measuring free testosterone. Therefore, I am just trying to discuss with you that total testosterone, which is very easily measured, and most of the laboratories are performing a CLIA test and they're measuring total testosterone. That helps. But in certain situations where we need to do free testosterone, that can be done by the mathematical formula. But in that case, you need SHBG measurement. If you have SHBG and total testosterone, Vermeulen formula is there by which you can measure the free testosterone, though it has a limitation of actual measurement of free testosterone. And that being if the testosterone level is quite low, this formula doesn't hold very true. Therefore, some free testosterone assay procedures are indicated. But remember, the testosterone should be measured between 7 to 11 a.m. Though the circadian rhythm is there, many do not believe it, that there should be the diurnal variation in measurement of total testosterone, but it does have effect as it is high in the morning hours. So we must measure it between 7 to 11. If testosterone levels are below or at the lower limit of accepted normal male value, that is 346 nanogram per DL, a second measurement along with LH or SHBG is indicated. But if the value is more than 346, you don't require measurement of gonadotropin or SHBG, because as such, you are not dealing with very severe testosterone deficiency. Analytical method for measuring free or bioavailable testosterone, as I said, direct RIA, which is not available in most of the places. Radioimmunoassay has phased out almost practically, except very few laboratories are doing it. But most of the laboratories are now have switched from radioimmunoassay to chemiluminescent assay. Physical separation of protein-bound testosterone, it is very accurate, equilibrium dialysis, but it is very expensive. It can be used only for research purposes. Ammonium sulfate precipitation, technically simple, it can be done, but accuracy is a question. Calculating using algorithm based on the law of mass action is helpful, and we usually do this for measuring free testosterone. Otherwise, most of the time we don't require. We must remember the testosterone level cutoffs. The total testosterone 231 nanogram per DL or free testosterone 5.2, testosterone deficiency is likely and they require testosterone therapy or testosterone replacement. Total testosterone between 231 to 346 or free between 5.2 to 6.5. Consider testosterone replacement, because this is a state of partial testosterone deficiency, and this needs to be confirmed by sex hormone binding globulin assay. If there is a low free testosterone index, they require treatment with testosterone. If the testosterone level is more than 346 or free 6.5 and above, actually you are not dealing with testosterone deficiency and don't need to replace with testosterone in such cases. We use a questionnaire for hypogonadism diagnosis, and this is very good screening tool. There are 3 types of questionnaire available. One is ADAM, that is adult deficiency or androgen deficiency in adult male, or another is the aging male symptoms questionnaire, and third is Massachusetts male aging study questionnaire. But ADAM is very good, and we are using ADAM in most of our patients. There are 10 questions, and the questions: do you have a decrease in libido? Do you have a lack of energy? Do you have decrease in strength, lost height, enjoyment of life is reduced, you feel sad or grumpy, are you your erections less strong, have you noticed a recent deterioration, are you falling asleep after dinner, has there been a recent deterioration? So 1 and 7, if this is there, along with that, any 3 of the 10, you make a diagnosis of testosterone deficiency. This is very easy, and you can subject these patients for testosterone assay as well as gonadotropin assay. MS questionnaire is little extensive. It has 2 parts, and I'm sure most of clinicians may not like it, but you can have this, and the scoring is that 17 to 26 asymptomatic, 27 to 36 mild symptomatic, and above 37 to 49 is moderate, and more than 50 is severe. So diagnostic evaluation of adult man with suspected hypogonadism, presence of one component of other metabolic syndrome or clinical symptoms or sign of testosterone deficiency or erectile deficiency, assess total testosterone. If it is less than 250, initially I said 246, 250, consider more than one of the following tests depending on the clinical situation: gonadotropin, free testosterone, prolactin. You can also measure estradiol, thyroid hormone, adrenal axis should also be looked at, karyotype, if required, fertility status, testicular ultrasound, MRI, and possible cooperation with an andrologist or endocrinologist referral is required here. If the total testosterone is between 8 to 12, that is 250 to 350, proceed with the trial of testosterone, because these are the cases with partial testosterone deficiency, and they might be benefited by testosterone replacement, but then you have to assess using questionnaire. And if there is a problem of erectile deficiency, you can have other modality of treatment, 5 that is PED5 inhibitors, or that we know sildenafil. These drugs can be tried for erectile dysfunction. If it is more than 350, assess free testosterone, and if this is more than 6 or more than 8, you don't require. If it is less than 8 or 6, you have to give a trial of testosterone replacement in these patients. So to summarize, majority of international society have defined male hypo as a clinical syndrome caused by androgen deficiency, which can adversely affect function of multiple organs. And I've said low energy, or they have they can share a feature of metabolic syndrome. Male hypogonadism could occur due to primary, secondary, or mixed etiology of testosterone deficiency. They might also have testosterone insensitivity. Diagnosis of male is comprised of clinical symptoms and biochemical assay support, testosterone and LH, and we can make a diagnosis in most of the cases with testosterone deficiency. Thank you very much. If you have a question, I would be happy to answer.
Thank you very much, sir. Thank you. It was a very nice presentation. How clinically, while sitting in the clinical chamber, by Adam's question and other questionnaires, we can find out whether there is any evidence of hypogonadism or not. Sir, what should be the best investigation, single investigation for going for investigation? Free testosterone?
Yeah, free testosterone, as I said, that we should not rely on the laboratory test for free testosterone. Not only it is expensive, but it is also difficult. As I said, the gold standard is dialysis method that is not available. Somebody claims that free testosterone has been done. Again, this would require reassessment. So best thing is total testosterone and LH together. If you have LH low and testosterone low, total testosterone low, less than, as I said, less than 250, you think of testosterone deficiency in these cases, and you should look for the etiology. Could be hyperprolactinemia or pituitary cause, or somebody has a functional testosterone deficiency that can be identified. So best method to make a diagnosis of adult testosterone deficiency is LH and testosterone.
LH and
that is total testosterone.
Right. Thank you, sir. Thank you very much. It was a really nice presentation and made us wiser for evaluating our patients of hypogonadism. Thank you, Dr. S.K. Singh, sir. Now we move towards the second talk of our this session. And that is again a very interesting topic, treatment of androgen replacement therapy. For a long, androgen replacement therapy has been in the controversy whether it is useful or has any side effects. For this, again, we have very brilliant endocrinologist from India. He is the professor of endocrinology, IPGMER, Kolkatta, and he is at present honorary secretary of Endocrine Society of India. He is Dr. Sujoy Ghosh. Dr. Sujoy Ghosh, you can start your talk right now.
Thank you, sir. Hopefully I'm audible and my screen is...
Yes, you are audible.
Right. Just a small correction. I'm no longer the secretary of the Endocrine Society of India, but thank you anyway.
So last time...
last year, until last year, I was secretary of the Society. And it's always a pleasure, particularly to speak in front of my respected senior professor, S.K. Singh, sir. Sir has given a brilliant presentation and set the stage because he has actually defined how we actually diagnose and when we suspect androgen deficiency and hypogonadism in males. So I'm going to talk about androgen replacement therapy. And, you know, this is one of the books which has actually been very controversial, whether testosterone therapy is a miracle or a killer. And I will start with two illustrative cases. And at the end of the talk, I'll come back to these two cases. So 52-year-old male, type 2 diabetes for 22 years, reasonably good glycemic control, who has loss of libido and inability to maintain an erection, has tried phosphodiesterase 5 inhibitors, is not happy. Secondary sexual characteristics are okay. Total testosterone is around 220. We'll come to that later again. And lipids are slightly off. The second is a 38-year-old gentleman who's had a snake bite history 3 years ago, which required hemodialysis, clearly telling us it was a vascular toxic snake bite, which led to acute renal dysfunction, and was diagnosed with panhypopituitarism and is already on corticosteroids and levothyroxine replacement, complains of low mood, low libido, and poor sexual life. Testicular volume on the lower side, 8 ml bilateral with loss of body hair, LH and FSH lowish with a low testosterone. So when we are talking about androgen replacement therapy, the first bit of the background has already been discussed by my respected senior sir, Professor S.K. Singh. So when we are talking about replacement, we have to know, when do you replace? How do you replace? How do you follow up? And what are the red flags that you look out for? So why is there so much of confusion about androgen replacement therapy in men? Unlike women, where menopause is a watershed event, andropause is not such an event, and whether it exists in every individual is questionable. And most of the time that as endocrinologists that we see people on testosterone, it's actually unwarranted and not indicated. And perhaps as endocrinologists, we stop more people from getting testosterone than start. So I'll be talking about guideline-based usage in terms of the recommendations of androgen replacement. So there are several guidelines. Sir was talking about the guidelines of diagnosis and the various questionnaires, for example, for diagnosis. Similarly, there's a whole lot of guidelines that people have been using. Honestly speaking, the European male study actually has given us probably the greatest insight in terms of androgen replacement therapy. So there are various societies which has talked about various things, and I'll be talking predominantly on the basis of the European Endocrine Society and the American Endocrine Society guidelines. So it is thought that the magnitude of hypogonadism in men keeps increasing as we age. So maybe about close to 20% of men in their 60s would have hypogonadism, whereas that number would go up to around 30% in 70s and maybe even up to 50% in 80s. And in this particular figure, you can clearly see that the testosterone level gradually starts going down as we age. Now, the indications of testosterone therapy as far as the US FDA is concerned talks about that replacement therapy in men who have low testosterone level, and along with it, you have to have symptoms of hypogonadism as per the questionnaires, particularly the ADAM questionnaire as described in the previous talk. The second group of individuals is a much easier, non-controversial area. These are individuals who've got a congenital problem or an acquired problem of hypogonadotropic hypogonadism, resulting from either a tumor, trauma, or radiation, or in the second case, as I discussed, from snakebite. So the symptoms have already been discussed in the previous talk, but just a very quick recap: decrease in spontaneous erection, decreased nocturnal penile tumescence, decreased libido, decreased growth of secondary sexual hair, and maybe even change in the testicular volume. And the commonest diagnostic criteria that we usually tend to talk about is in males, the normal range of morning testosterone is around 300 to 1000 nanogram per DL. Hypogonadism is defined when the serum testosterone, that's the total testosterone, is less than 300. Of course, clinical judgment is required when the testosterone levels are normal with symptoms suggestive of deficiency. And the total testosterone less than 205, 405.9 is actually below the 5th centile. That's when you start suspecting that things are going wrong. In older individuals, we should try to aim for testosterone levels to be between 500 to 800, whereas in the younger individuals, we would aim for around 600 to 900 nanogram per DL. So usually, like Dr. Singh sir quite clearly stated, that we should have at least 2 early morning readings, preferably between 8 a.m. to 10 a.m. And we should also test for secondary hypogonadism with tests like LH, FSH, prolactin, thyroid functions, a complete hemogram, and a comprehensive metabolic panel. Particularly look for diabetes, dyslipidemia, and liver dysfunction. So total low normal testosterone with symptoms, along with alterations in SHBG and albumin, we will be able to calculate the free testosterone, which might be useful in particularly certain individuals like obesity, type 2 diabetes, hypothyroidism, and liver disease. And we all work in a circumstance where we do not have access to LCMS method of measuring free testosterone, and therefore we have certain limitations there. So semen analysis, pituitary MRI, testicular ultrasound and biopsy, and genetic studies are other optional tests that we would actually have in certain circumstances. So in terms of the cutoffs that we were talking about, various organizations have talked about various cutoffs, but whatever you use, try and stick to it. We are quite happy with a cutoff value of 300, or even some would say 350. That's good enough in terms of our total testosterone cutoff. So if you talk about the history of testosterone replacement, we've come a long way in the last 150 odd years or so, from various preparations about which I will talk a little bit. Sorry, my screen seems to have frozen. Just give me a second.
Not getting your voice.
Sir, my screen has...
Yes, seems to be hanged up.
Yeah, there's something wrong. Yeah, let me, sir, share the screen again.
Yes. Yes.
There's something wrong. It's not moving, sir. The screen has stopped moving.
Yes, your screen is visible.
Sir, screen is visible, but it's not moving.
Okay.
Just give me a second, sir. Let me try. Can you unshare the screen, sir, so that I can again try?
Ajay, I talked to that.
अजय उनका स्क्रीन शेयर नहीं हो पा रहा दोबारा से
सुंदर भाइयों पेट लोगों चुप लो तुम भी
लो
मैं तुम्हारा
Dr. Sujoy, the
yes sir
ID says that he is allowed again to share the screen.
right okay let me see if it works now sir
ले
50 in terms of what we use for management of testosterone or androgen replacement. So we have various preparations, some of which are intramuscular, some are gels, some are patches, and there is also some drugs which are available for oral route administration as well. So if you look at what we are trying to do in terms of replacement is we are trying to replace the testosterone level as well as the free testosterone level in the best possible manner. And if you see, the levels are perhaps very well maintained with the variety of different kinds of replacement that we are currently using. So in the Indian scenario, what do we have in terms of...
क्या हालचाल है तो कमजोरी कब जाएगी
And
कमजोरी क्यों आती है
why is it the background, sir? Right. So we can think of whatever preparations are available in the Indian scenario. The first would be the testosterone gel. Example of that is the Sarnos gel that we have been using, though supply sometimes might be an issue, which is a 1% weight by weight, and a 5-gram presentation is available. We have oral capsules. You have got testosterone undecanoate, which we have used very rarely, though. Again, Sarnos is available, 40 milligram strength. And most commonly what we are using is the variety of injectable forms of testosterone. Of them, the cheapest is the mixture of propionate, phenylpropionate, decanoate, and isocaproate available as Sustanon. And also we are also using pure testosterone enanthate. So if we are talking about the testosterone gel per se, it should be applied over the upper arm and abdomen, not around the genitalia, and it should be preferably in the covered area of the body so that it does not easily get transferred to a child or the partner. Usually we start with a 50 milligram morning dose once daily and increase gradually by about 25 milligram. Maximum we go up to about 100. And we test after about 2 to 4 weeks of starting therapy to measure levels. Most physiological, and the levels drop almost immediately after we stop using it. There is very little fluctuations, but of course, cost and sometimes limited availability is an issue with the testosterone gel. The next we are talking about is the oral capsule. This is undecanoate, it is esterified, bypasses the liver, absorbed in lymphatics. However, the bioavailability is sometimes unreliable with very fluctuating serum levels with a very short half-life, and you require 40 milligram capsule per day with food. We are worried about GI side effect, particularly liver effect. It's not marketed in the United States and the costs are very high and usually not recommended. The next is the injectable form. This is the most widely prescribed, relatively cheap, relatively easily available, though we know that these injections can actually lead to high peak and low troughs. So there is wide variations, particularly the total testosterone level might reach supraphysiological levels. When we are trying to actually check for dose adjustment, we usually test midway between 2 injections to look at the trough level. Our target testosterone level in there is about 400 to 700 nanogram per ml. And we have to monitor for erythrocytosis. Rare complications include pulmonary oil microembolism. And you usually, particularly if it is for induction of puberty, we start very low. And even for androgen replacement, often we gradually up titrate the dose rather than giving a big dose to start with. Usually the Sustanon is available as 250. And we gradually up titrate every 4 to 6 weeks to maximum around there, depending on the symptoms, improvement, and the testosterone level. So what are the expected benefits of testosterone level? So you can hope that, particularly if there was mood change and depression, that would improve. Muscle mass is likely to improve. Bone mineral density is likely to improve. Energy levels are likely to improve. Erection and libido is likely to improve. The relationship, however, with hypogonadism and sexual function on one hand and metabolic dysfunction on the other hand is pretty complex. It's not as simple as this cartoon tries to show in here. There has been a lot of controversy as to whether testosterone replacement actually worsens diabetes or improves diabetes, and whether it increases cardiovascular mortality or decreases cardiovascular mortality. This particular article is actually a meta-analysis which shows that clinical trials demonstrate that testosterone replacement therapy improves insulin resistance and improves glycemic control, reduces body fat and particularly truncal obesity, improves lipid levels. Now remember, this meta-analysis included only in clear-cut patients of testosterone deficiency. All of the other circumstances where people are using it in doubtful circumstances, there such kind of results might not actually be replicated. In terms of the lipids, use of testosterone might improve the lipid profile, but effect on HDL remains controversial, and long-term studies might show that actually HDL may rise after 12 months following an initial drop. Muscle mass, we know, is actually supposed to improve the lean muscle mass. The fat supposedly decreases. There's decreased circulation of free fatty acid and adipokines, and that results in reduction of insulin resistance. I was already talking about bone mineral density and bone health. Testosterone replacement will improve bone health in individuals who are androgen deficient. Professor Singh sir already talked about that a lot of people might have unrecognized, unexplained anemia which are responsive to androgen replacement therapy. There are several such studies to show that actually unexplained anemia due to hypogonadism might respond to androgen therapy. However, we have to be careful that we don't cause erythrocytosis in the otherwise normal individuals with no anemia. When we are talking about monitoring, before we even contemplate androgen replacement therapy, we have to measure hemoglobin, hematocrit, lipids, liver function test, PSA, and morning level of testosterone. And we should also consider assessing bone health prior to starting therapy. When we are monitoring, we usually monitor after a month's therapy of morning testosterone level. 3 to 6 months after treatment, we should be still keeping an eye on the testosterone level, but more importantly, monitoring for the metabolic parameters, the liver function test, the lipid profile, the PSA, the estradiol in some situations, hemoglobin and hematocrit, and blood pressure. Annually thereafter, we should look at morning testosterone, the metabolic parameters, and blood pressure. If the PSA is greater than 1.4 nanogram per ml, at any point of time, the patient should be referred to a urologist, keeping the drug therapy on hold. If hematocrit rises above 54%, that is polycythemia, we should stop therapy. We should look for signs of sleep apnea on annual follow-up visit, because that might actually get worsened with the use of testosterone therapy. 1 to 2 years after the start of DEXA scan, we might repeat the DEXA after the start of therapy to see whether there's an improvement in the bone health. And hyperestrogenemia can actually be a side effect of replacement. Aromatase inhibitors in such circumstances are actually needed. Target therapy, like I've said, don't overdo things, don't go for supraphysiological levels. In terms of the adverse effects, buccal tablet can irritate, we are not using it. Testosterone gel we do use, but be careful that it does not get inadvertently transferred to the partner or the child. Testosterone patches can cause skin reaction. In India, it does not work well. It just comes off because of the humid weather that we are here in India. Injectable ones, because there is such peak and trough effect of the injectable one, there might be swings in the level, which might lead to changes in the mood, energy, and libido fluctuation. Erythrocytosis is something which is real, which might happen. And rule out prostate cancer if the PSA rises, and there is no significant effect on the lower urinary tract symptoms or the BHP. Now, one of the major issues that has remained controversial over a period of time is what is the cardiovascular effect of testosterone replacement therapy. Now, at least this meta-analysis tells us that if you're looking at short-term measures, there is no evidence that testosterone increases short or medium-term cardiovascular risk in individuals with hypogonadism. However, we do not have long-term data, and we need long-term data to prove safety of testosterone replacement. There are certain contraindications that we've got to keep in mind, like breast cancer, prostate cancer, heart failure, recent myocardial event or cerebrovascular event, untreated or worsening sleep apnea, hematocrit is rising. When somebody is planning fertility because the sperm count might go down, a palpable undiagnosed prostatic nodule, baseline PSA if it is high. So coming back to the first case, we started injection testosterone in Anthet 250 milligram once in every 4 weeks. The trough serum testosterone was measured at around 3 months, which was around 390. The dose interval we then reduced to 3 weeks and then 2 weeks, and then found that gradually there was great improvement in libido, well-being, mood, and sexual life. After 6 months, we evaluated the lipids, which actually seems to have not done badly, and the patient had follow-up investigations in 6 months, which are satisfactory. Moving to the second patient who had a snake bite and hypopituitarism, hydrocortisone and levothyroxine treatment was optimized. We started injection testosterone 200 milligram once every 4 weeks. At 3 months follow-up, the trough serum testosterone is 540 nanogram per DL. Mood, well-being, and sexual function have improved. Patient is maintained well on 4 weekly injection testosterone, and there is no adverse events recorded at follow-up. So I've already talked about the pros and cons, the possible benefits in terms of the mood, the sexual motivation, desire, muscle strength, increased lean muscle mass, decreased body fat, improved bone mineral density, improves hemoglobin level. Cardiovascular health and risk is controversial. Lipids might actually remain same, with HDL might be worsening. The PSA might increase, prostatic malignancy might increase, acne, testicular atrophy, gynecomastia, polycythemia, and sleep apnea are the reported risks. So I shall stop there for any questions. Thank you very much.
Thank you, Dr. Sujoy. It was a very nice presentation. Very well clearing that what benefits we are expecting with the testosterone therapy and in which patients. Dr. Sujoy, you told that with testosterone therapy in the hypogonad patients, we have various metabolic benefits. So what can be the mechanism, and why do we not find in the other persons who do not have deficiency of the testosterone?
Right. So, both there are several studies to suggest that when there is androgen deficiency, there is increase in body fat, particularly central obesity, and there is loss of lean body mass. And a combination of this probably leads to increase in insulin resistance. Now, when we are actually replacing androgens in the form of testosterone, there is an increase in the muscle mass, and there is a decrease in the total body fat, and there is a change in, therefore, the adipokine levels and the other adipokines in the body. All of that might actually lead to improvement in insulin resistance and improvement in metabolic parameters, particularly insulin sensitivity, improvement in diabetes, and decrease in central obesity, which is detrimental for metabolic health.
So in the patients who have androgen deficiency, these benefits will be obtained, right?
Yes.
But in other conditions, like in many of the situations, it is, yes, you wanted.
Because in those individuals, you don't have this background.
Yeah.
That is why that bit will not be reversible.
So we have to use it judiciously. When there is deficiency, we should give testosterone therapy, right?
Yes.
So what should be the final message to the participants?
Right. I think the first message should be, let us not abuse testosterone therapy, number one. Yes. Number two, let us have an open mind about who we think might be androgen deficient, and be judicious in the way we diagnose individuals with androgen deficiencies. The one where we have, say, a pituitary problem or other etiology for definitive androgen deficiency, we do not have a problem there. The major problem is in an aging male, maybe who is obese, who's got diabetes, who might have functional partial hypogonadism. We have to be very, very careful in whom we label as androgen deficiency. And I think Professor Singh sir has actually given a beautiful presentation there to say that, your threshold for thinking of a diagnosis should be low, but your criteria for actually diagnosing somebody as androgen deficiency should be very tight. you have to have very clear-cut biochemical markers, and you have to have very clear-cut questionnaire-based diagnostic markers. So in both of them, you combine the two, and then you diagnose, then you give a clinical trial, and then you see how an individual is responding, rather than, you know, when you particularly go to several of these diabetes conferences, everybody is talking of late onset hypogonadism and the benefit of androgen therapy. Let us not, you know, go left, right, and center for androgen replacement therapy.
Right, very right. Thank you, Dr. Sujoy. I can say that both of the speakers have given very good view of how to diagnose hypogonadism judiciously, not to overdiagnose, and then judiciously treat patients. Then only your patients will be benefited with the testosterone therapy. So it was really a nice session, and we thank you for your nice presentation. And if there are any questions for the participants, since as there are no questions, we thank you very much for your presentation. And really, it was a nice presentation.
For inviting me.
Thank you. Thanks for coming and giving this lecture. Thank you, Dr.S.K.Singh, sir. Thank you, Dr. Sujoy, Dr. Minal. And we meet on the 7th of August for the next session. Next Sunday, they will be off. So we will completing the course next week, in the next session. Thank you, Dr. Sujoy. Thank you, Dr. Bye-bye. So all the participants,